Okay, so welcome again to the 10th Complex PCI 2025. So this session will be a live case 3, calcification management with imaging and physiology. I'm Dr. Koo from Seoul National University Hospital, and it's my honor to moderate this session with Professor Seung-Jung Park. I would like to also invite the panels, experts in this area, Dr. Cha, Dr. Chiam, Dr. Jo, Dr. Che, Dr. Ho, Dr. Lee, Dr. Okutsu, and Dr. Sadamatsu. So as we are a little bit behind the schedule, so why don't we just move directly to the Asan Medical Center. Professor Duk-Woo Park?
Okay, can you hear me?
Yes, I can, loud and clear.
Okay,
Whoa.
thank you for the joining the afternoon live case session, and I'm gonna introduce our team. And I'm D.W. Park from Asan Medical Center. Is a first assistant senior fellow, and Dr. So-Yeon. Second assistant Iman is our visiting fellow from Bahrain, and so we started a relatively young patient. And Dr. An, can you explain the patient background?
Yes, thank you, Professor, for your introduction. I'm Iman Murad, interventional cardiology fellow here at Asan, and I would love to introduce this case. This patient is a 56-year-old gentleman who had presented to our outpatient clinic with history of recurrent chest pain on minimal exertion. He has history of left main bifurcation PCI earlier this year in January at another hospital. His past medical history is positive for diabetes, hypertension, dyslipidemia. So his clinical presentation was consistent with unstable angina. His ECG shows normal sinus rhythm at a rate of 60 beats per minute with no acute ischemic changes. His chest X-ray was unremarkable. His echocardiogram shows normal LV systolic function with no regional motion abnormalities. His baseline coronary angiogram shows a normal and dominant RCA. Coronary angiogram of the left system shows the cranial view shows a normal mid to distal LAD. From here, we can see a patent left main to LAD stent. On the caudal views, we can see clearly severe ISR of the proximal circumflex stent with a jailed OM and a jailed diagonal, however, with TIMI-3 flow. We also have a jailed high OM with a TIMI-1 to 2 flow. So our plan for today is to tackle the ISR of the left circumflex using OCT guidance.
Okay, so and would you like to show us today the first coronary angio case? And this is area coral view. You can see it's a very tight subosteum. And this patient is underwent left main complex PCI distal bifurcation lesion at the 목포 한국병원 and 목포 Korea Hospital. And looking at the left main, seems like there are two stent stroke. And I think we just guess would be he underwent Coulot stenting, LAD first stent, and then the suck to the left main. It's left main part. We can see the two overlap stent. And as you can see, the subosteum is nearly TIMI 2 or 3. It's very almost obstructed region, and the OM branch is big, and the patients complain highly unstable angina, just 3 and 4 foot walking, and he feel the chest pain. And next one. So this is spiral view, and left main prox LAD is a little neointimal hyperplasia, not tight lesion, but this today target lesion is subosteum, is a highly stenotic lesion, almost more than 99% obstruction. So I think this patient is 11 months ago underwent complex stenting in another hospital, and left main the ISR region and the unstable angina. And this is some the difficult case, and is our today the lesson from our left main PCI is if you experience left main ISL lesion, how do you treat? What is your strategy? Would be our key point in this case. So at this moment, we would like to hear some opinion, panel or moderator.
Okay, thank you, Dr. Bach, for sharing the very a good case example. So any questions, comments from the panel? So I think that even though it can happen, but the 11 month may be too short. So you're going to do an intravascular imaging, but it is very important to understand the mechanism of restenosis. So it's a little bit unusual, young patients and recent strong, severe aggravation in a very short time. So can you expect some other elements when you do before any imaging assessment or do additional PCI?
Yes, usually, more than 10 years ago at the time, 15 years ago at the time, we do routine angiography after left main and complex PCI. Nowadays, most centers don't do that. And in the world, most centers don't do a routine follow-up angiography. But most patients is okay, but it's based on previous data, usually diabetic patient and the complex two-stand technique and the smoking and the incomplete opposition, and that would be stand on the expansion. That would be some risk factor for this patient. So, and we already checked up imaging evaluation we can achieve what is the underlying mechanism of the ISL lesion. So, it's one of the important key points. And when you treat the left main ISL lesion or any ISL lesion, and the imaging is essential. Is very good to delineate the underlying mechanism. What is the main mechanism of the ISL lesion? According to the ISL lesion mechanism, we can decide the additional treatment modality.
Okay, I can check the angio. The circumflex have so much movement. Maybe we have to check the stent fracture. If there is a stent fracture, that maybe the treatment strategy will be different from the usual instant restenosis.
This is Choi from Maju University. Actually, instant restenosis mechanism is very essential for this patient. This patient age is relatively young, even though very multiple risk factor. So I would like to imaging study perform for this patient. However, systemic risk factor is also important because relatively short period, 11 months, right? Yeah, so risk factors such as diabetes or dyslipidemia are well controlled in this case, or platelet inhibition study, did you perform for this patient?
This patient has a diabetic, and repeat LDL level is less than 55, is controlled well. Our center, we didn't routinely check it up the platelet function test. And some thrombotic lesion can progress to the ISL lesion. That is good point.
Yeah. Okay, so I also agree, routine platelet inhibition study is not recommended in the current area, but instant restenosis patient, I strongly recommend for this patient.
So Dr. Bach, you mentioned that you've already done the imaging, but before you show the imaging, before you show the imaging, so you did an excellent study, Octibus, which compared the IVUS FFR, IVUS and OCT comparable. So for this kind of situation, is there any rationale for your imaging, either IVUS or OCT for this case?
Yeah, so in Octibus data, in the one of the sub-study, complex region is published in JACC, in the main paper published circulation. Published in the JACC journal, in the ISL lesion, especially OCT is much better than the IVUS. So also there is some the clinical benefit, and is published in JACC. Also, we are mainly focused on the ISL lesion. Is another sub-study is already done, and we will submit to another journal. So I'm going to show some concern is about the left main region, how can you do OCT guided evaluation? We're gonna demonstrate the how can you do OCT guided evaluation. So such tight lesion, the OCT does not pass, and we do 2.0 pre-dilation first. Yeah, so wire is the shown blue, and this is 2.0 we already performed, and then we are evaluation to the suck is what is the underlying mechanism, and we already check it up the IBUS from the prox LAD to the left main, and this is check it up for the suck to the left main. Okay, this is a OCT Abbott, and the system is Ultraon, and the Ultraon is very good. Okay. Okay, ready? 나이트로 좀 적어. So we using 7 French XB지? 적힌? Okay. Okay. Just wait a minute.
So it's manual injection, right?
Yes, right. Okay, 테스트. 자, 한번 찍어볼게요. 자, 준비됐지? 자, 풀샷. 오케이, 굿. 이거 좀 뺍시다. So we're gonna show the OCT finding. 뷰가 안 좋네. This is Ultraon system. 이게 안 좋으면 아까 찍어놓은 거 보여주는 방법도 있으니까. Okay, this is called registration.
Okay, so while the system is working, so you did the IBUS for LAD?
Yes, we
So
checked it up
is there any
already,
particular
OCT.
reason, or it's because that it's a live demonstration for this
Yeah,
meeting?
it's LAD is initial impression is there is no severe ISR lesion, but on the OCT and there is some severe. LAD 보여줄 수 있어 지금?
OCT.
Okay, so we are looking at the LAD cranial view.
이거 시간이 걸려? 아하, 이거 막상 잘 보여주려니까 이런 또.
Okay, so this happens all the time. So please take your time so we can wait.
예, 오케이, 아까 한 이미지로 보여줘봐. 오케이, 그러면 3.25.
We know that this co-registration system is really helpful because that when you classically do the intravascular imaging, it is very difficult, especially the beginner, to co-register the lesion location in angio and the intravascular imaging. But with the help of this co-registration, it becomes much easier and to get the better insight from the co-registered images.
다 키는 데는 얼마나 걸려요? Okay, we're gonna show later, and we start to proceed our procedure. On the based on OCT image already we recorded, and there are the mainly neo-intimal hyperplasia, and then also the stent expansion on the expansion is not severe. Okay, 한번 봐봐.
Dr. Park, is there any stent fracture or there's
LAD부터 한번 보여주자.
So the question is that whether there was an evidence of stent fracture.
Is no stent fracture.
No. So that means that it's the main mechanism purely instant restenosis, not the mechanical one. Am I correct?
이게 LAD부터지? Okay. Okay, we're gonna show the OCT from the LAD to the left main, and this is a previous stent. And the stent, I think it expanded well. This is a neo-intimal hyperplasia, the prox LAD, and this is the LAD ostium. You can see, 조금만 더 뒤로 가봐. you can see the stent expanded well is the main mechanism of neointimal hyperpressure, nearly impacted. Angiographically, looks like intermediate region by IBUS, by OCT is lumen area. Can you measure the lumen area at this point? At 1.23 is a very tight lesion. The mechanism is underlying the neointimal hyperpressure. And then could you play again? Is 앞쪽으로 쭉. Left main subaostium is coming. And the distal left main, here is a two stent. Also is a neointimal hyperpressure. Yeah, here extended to the left main ostium. Also we check already the suck. And we do 2.0 and pre-dilation using compliant balloon.
Yes, I think this image is really, really educational because if I do even if I carefully watch that LAD ostium, it looks fine, but the lumen area at the LAD ostium is as small as 1.2, 1.3. It's amazing
this
to see.
This is a suck to the, could you, Can you see that there is some plaque dissection
so we can see
by balloon, and here. Stent is expanded well, and as you can see, the main mechanism of ISR is there is some crack of the stent. Over here, the subaostium. Over here, looking at this moment is this is the most tightest portion is the subaostium.
Dr. Park, so how big is the stent before? I'm just curious. It looks like the stent is undersized a little bit in here. So can it be because of stent undersized, that's why we got this ISR in here? Rather than stent under expansion?
I don't know exact information. Is that was do? Is which size stent was done? Is we don't know. It's another hospital. But it's just a visual estimation. Stent expanded well. Its main mechanism was a ISR lesion. As you can see, this is the subaostium. It's nearly totally is a neointimal hyperplasia compact at the subaostium region. So, and we know. And there are relatively stent on the expansion, but it's not main mechanism. Main mechanism is neointimal hyperplasia, and also beyond this, our initial expectation, there are proximal region is very tight. This lumen area is less than 1.5. Subaostium is very tight. So at this moment, what is the treatment strategy? If you don't do refer to the bypass surgery, that is another discussion point.
Okay, so that we've now seen the angio and OCT images. So can you explain us about your strategy? Because I think it's time for us to go to the second room and coming back.
I said, I'm gonna briefly introduce I'm gonna apply to the both. I'm gonna treat in both branch first, and based on the OCT findings, 10 is at least more than 3.0. I will do 3.25 cutting balloon. And there is a region perforation, and the prox suck to distal main. I apply to the cutting balloon 3.25, and then I'm gonna move to the LAD, prox LAD to left main, additional cutting balloon in both sides, and then I'm gonna do 3.5 non-compliant balloon to the prox LAD suck ostium, and then additional 3.5 non-compliant balloon prox LAD left main, and then do final kissing balloon dilation using 2 non-compliant balloon, and then we are finally moved to the DCB. We use secant fleece, DCB 3.5. DCB balloon is prox suck to the left main, and the left main part also ISR lesion, and DCB balloon prox LAD left main, final DCB kissing, and then finish. That was my strategy.
Okay, so do we have any strategy, a plan for fixing that big diagonal branches? It also looks big. And
so in the, we already put the wire at the 3 part, and the OM branch, and the sucker branch, and the LAD branch. After final DCB kissing balloon dilation, there was some much narrowing diagonal branch, and we will do further procedure.
Okay, so thanks for sharing the great case and the plan. So we'll come back a few minutes later. Okay, so now it's time. Okay, thank you. And now it's time to move to the another room of the Asan Medical Center. And so Professor Kang. Okay, so Dr. Kang, can you hear us?
Oh yes, I can hear you.
Okay, so thanks for joining the live demonstration. And would you introduce your team and case for us, please?
Hi. Yes. I'm Dr. Do-Yoon from Asan Medical Center, and I'm working with Choi from Changwon Hanma Hospital, and our senior fellow Gi-Han Kim, and our senior technician Yang Soo-Jang is Kang Soo-Jang is working with me. And can you please present our case?
Thanks, Professor Kang, for introduction. My name is Gi-Han Kim. I am a second-year cardiology fellow at Asan Medical Center. I would like to present today's case. A 63 years old female presented to a hospital with chest pain. She had a positive treadmill test and a newly developed perfusion defect on the Salyum scan. She had previous history of hypertension, diabetes, and hyperlipidemia. She was diagnosed with stable angina. The ECG showed normal sinus rhythm. The chest X-ray revealed no pulmonary congestion or cardiomegaly. Echocardiography demonstrated normal cardiac function without regional roll motion abnormality. Here is the baseline coronary angiogram. The RCA only showed mild disease. The left circumflex artery appeared nearly normal.
And can you please show today's angiogram?
Yes.
Oh yeah. Oh yeah. There's the
Yeah.
already.
The proximal to mid LAD demonstrated severe calcified region extending from the distal left main. Our plan is to treat a severe calcified region in the proximal to mid LAD and the distal left main. Thank you.
As a patient is the middle-aged woman and visited the hospital for the mild chest discomfort because of the low grade exercise. However, the functional test showed a significant abnormality. Actually, she did the angiography 6 years ago and did the medical therapy well for mid-LAD intermediate stenosis, and it developed. And because the time is not enough, so I will continue. Yeah. Can you please show today's image? Yeah.
This case is not included the FAME main trial?
She was included the fate minus for the distal left main involvement and the angiography group.
Angiography group? You
Yeah.
mean? All right, great.
Yeah. Yes. And the problem is the severe calcification as well seen in angiography. It's just like to the train track. That means the angiographically severe calcification. Next. And cranial view, you can see that there are very severe calcification from distal left main to mid-LAD. I will concentrate this calcified region. It's very tight stenosis. And next, I did the wiring. Next. Yeah. Fortunately, there is no big diagonal branch. This is the OCT guide catheter and does not pass. Actually, at first I used the XB guiding, but there was the pressure damping, so I changed it to Jokin. So I tried insert the 2.5 balloon. Next. And it passed well. And without pressure 20 minus, it is opened. So I applied the balloon and mid-LAD severe calcification. And next, and this is the angiography after the NC balloon that shows the very ugly shape of the broken calcium at the mid-LAD. And I will continue to show you the OCT images and then we can discuss. Next. OCT, please. Yeah. This is OCT image from mid-LAD. Mid-LAD is normal, and then you can see lipidic plaque, and then balloon-related dissection, and then very severe calcification, 270 degrees, and here would be the ring calcification that has just one side breakage after the NC ballooning. And mid-LAD, relatively good shape, but proximal, you can see very heavy calcification surrounding whole vessel to proximal LAD. This is 360 degree, and tight stenosis at the proximal, And you can see the circumflex comes in at 6 o'clock and left main. Yeah. This is very heavy calcification. How I want to ask you about that, the treatment strategy.
So I think it's interesting because I thought that when I see the angio, mid-LAD lesion should be much more harder than proximal AD, but as OCT didn't pass, but you fortunately did a kind of make a big crack on this mid-LAD calcium. So the question is how we should deal with the proximal AD and the residual calcification. So any suggestions, comments from the panels?
Dr. Kang, this is Dr. Cha. So, thank you for your nice presentation. In the angiogram, the balloon expansion is not enough. So maybe NC balloon, maybe more the crack and more dissection. So in this situation, what do you prefer between IVL or the cutting balloon? As a root burning is one of the options to the diffuse calcified lesion.
Yes, thank you for your very important comment. And I selected smaller NC balloon because we don't know the exact vessel size and the thickness and the danger, how dangerous the calcium is. So I selected small NC and applied not so very high pressure. And even after small balloon, you can see very early dissection of the NC, the calcium. And after that, we all maybe agree we need more plaque modification therapy. And because the lumen itself is preserved, so I think that the balloon-based therapy rather than atherectomy would be better. And for cutting, actually, we can try it, but I'm a bit afraid of the risk of the rupture because the vessel size is not so big. And the calcium thickness is very thick, even in angio or OCT. So actually, my plan is to treat with the intravascular lithotripsy for this patient.
Yeah, I agree with you.
Dr. Koo's, and Dr. Koo's point is very important. We also thought that the mid-LAD would be the biggest problem. However, you can see the proximal LAD has more thicker calcification. We meet those cases in daily practice because the proximal vessel has the bigger vessel diameter, and there are some patients that has the more thick calcification, and we can open the mid or distal. However, the proximal lesion makes the stent the under expansion. So checking the imaging and for the plaque modification is very important for successful procedure.
So your strategy will be IVL for proximal, or do you do a cutting bone angioplasty first and we'll determine later?
I would apply IVL first for mid to proximal, whole the lesion.
Whole lesion?
Yeah, whole LAD lesion.
Okay.
This shock we can use the 120 times. So
but the issue may be the size of the balloon, because that the proximal lumen will be enough so that the may be tricky, but you will see. So Professor S.J. Bach.
That's right.
So you've been started with the same. You've been started with the rota, DCA, and cutting balloon, etc. Now that younger doctors are using IVL. So how do you feel about these changes in calcium modification?
We need the data more. So, to be honest, as an NC balloon, in the practical point of view, up to this point, I think it's quite enough, right? However, today, as a live demonstrations for the IVL something, however, the tightest portion of mid-LAD we have already, dilated. Maybe just in terms of a meaning of a pre-modification would be just cracking down, in terms of calcium, something like that. And then we're going to make a stent area by high pressure inflation of the regulating stent, etc. Finally, we want to do the DS, right? And so I don't, still, we need more data about that. However, honestly, in the practical point of view, NC balloon is quite enough.
May I ask a question?
Sure.
Excuse me.
Oh, sure.
So, do you think we need IVL in the mid portion? Because already creates the radi dissection. So I think the IVL is enough in the proximal part, because the proximal part we cannot create a dissection. But the mid part, we already created a dissection. So maybe the IVL is a little bit danger at that time in that situation.
Yes,
Because,
I think that's a good suggestion. But one good thing is that the IVL balloon can pass to the mid LAD, so it's good. So practically feasible, but the risk of the rupture in dissected segment and size difference, so that may be a kind of technical issue in selecting all the IVL, doing the IVL for whole lesion segment or only for the proximal segment. So choice is yours, Dr. Kang.
Yeah. Actually, I'm planning to treat the mid with IVL,
Okay,
but more concentrate on the proximal region, because still there's some difficulty passing the balloon. Yeah.
So balloon
I
size?
covered it. It's 3.0.
3.0. Okay.
The distal normal vessel size was 3.0, and at the lesion it was more than 3.25. So I selected this 4.
Inflate. Pressure. What pressure?
Pressure is 4, and then. And I'm now applying.
Starting.
Yeah, started. 10 times deflation. And vital sign is stable. Actually, in angio you cannot see how it was. Sa 4. And can you please show the machine or?
Show us.
It's that.
Machine.
I'm now applying.
Would you show us IVL machine dose, or just curious?
Deflation. Yeah. There's some difficulty because the line is a bit short.
All right. During the inflation of a balloon, anyway, the calcium would be cracking. There are some changes, on the dilate balloon is a full dilate balloon something.
But it seems even with only 4 atmosphere inflation, it seems to be fully dilated and much better than before.
And it's third cycle.
Yeah, it's working.
Dr. Kang, do you decide the balloon size based on the intravascular imaging or angiographic imaging?
I decided it upon the intravascular imaging. And also I saw the angiography. I will move a little bit proximally, and then once again 4. Now I'm applying the shock.
Just wait. We're gonna see the balloon inflation proximal part. All right.
Yeah. So proximal part is a little bit under dilatation.
Inflation once again. Okay. Yeah. Let's see.
All right.
Okay. Let's
this
see.
is cine imaging. You can clearly see.
Yeah.
And applying one more cycle. And I will move more proximal. Yeah, deflation. Yeah. Now move to more proximal.
You may need a very proximal area has also, insuffling calcium over there. Right, great.
Yeah, here
over
it
there.
is.
Right.
Yeah. 4. Patient vital sign is good.
Get that on. Balloon.
You can see that balloon is not expanded
not
well.
much expanded.
Heavy calcification.
Under
expanded.
So after the IVL, there are some changes.
10 times deflation. Yeah. In my mind, I think it's becoming a little bit larger.
Okay.
I don't know whether you agree or not. Once again, 4. 안 들어가게.
We can see the number is decreasing on the screen. What will happen if the number reaches 0?
Okay, it looks much better. Yeah.
It is. Yeah. Much better.
Yeah.
Just be.
I can.
If it becomes 0, we cannot use it more deflation. And I will move a little bit more proximally.
More.
Okay. Patient is okay. No. 4.
Okay, so it looks much better.
All right, still.
Yeah. I should
Uneven
move more forward. Yeah. deflation. 몇 번 남았죠?
4번 남았습니다.
Yeah. I'll concentrate more on the proximal with my 40 residual shots. That's too deep. Okay, 4. 4. 2, 3, 4, 5.
So how you decide how many pulse should be enough for each lesion? I'm just curious.
Deflation. Actually, this balloon gives the ultrasonic
120?
energy.
Yes.
Yeah, 120. Oh yes, this machine has 120.
Then how many pulse you
4.
think is enough for each location?
4. Actually,
How you decide?
There's no, yeah. I think it's up to the operator. So for this patient, I planned more concentrated on proximal. So I did the shock deflation, 40 on the mid and 80 on the proximal.
2번 남았습니다.
The smart strategy, to select the lesion and divide the numbers of the shock would be needed with more data. 4.
So we will look at the OCT and then look at the calcium thickness to decide how many pulse I should use for that lesion.
little bit better.
On OCT, you see the thickness of the calcium.
Yeah. Deflation. 몇 번 남았죠? And I'll move to more distal. Yeah. Yeah. The balloon is very bulky after use. So move from distal to proximal is a practical. Nominal. 4.
4.
Okay.
Last one.
This is last one. 1,
Okay.
2,
Okay.
3,
7,
4,
6.
5, 6. Yeah, now we are done. Deflation.
So real full use of the IVL
Yeah.
system.
I want 200 shot.
Okay. Okay. So the shot have been performed. So are you going to do an imaging?
Yes, I will. After some angiography.
Okay. So
부드럽게.
angio
Okay.
and
Yeah. Angio. Okay.
okay. So proximality looks even better.
Dissection.
Yeah,
Yeah.
look,
Dissection.
yeah, dissection is because of the
No
first
way.
balloon.
Anyway,
It was
some
just
changes
2.5,
even in
but
the
we made
proximal
large
part, right?
dissection.
Yes, I think proximal is a kind of key point for
Yeah.
this. So Dr. Kang, so after OCT, so we'll move to the
Alright.
Dr. Bak's
Okay.
room
yeah.
and we'll come back. So please show the OCT images.
오케이, 바로 봅시다. 네. 네. 왼쪽. 오케이, 보여주세요. 마이너스. Okay, this is the pullback from the medial AD. And I did not touch here yet. And this is the site of the
Cracking over there.
dissection that occurred with the first NC balloon. And visually, I cannot see big change. And we are moving to proximal region.
Dissection over there.
Yes, still there's some dissection. And you can see a very
Some cracking,
small
right?
cracks.
3 o'clock.
Yeah.
Yeah, 3 and 9 o'clock.
And
seven-
multiple
yeah,
cracks.
and multiple cracks.
cracks
lots of
here. Yeah.
Yeah.
Crack down.
So it just point out, it's interesting that the proximal, it really worked. And I'm not quite sure by the OCT that mid-dissected segment, I don't know whether there's extra cracking have happened there or not. But the proximal element, it really worked. Perfectly
Yes.
worked.
I believe now is the time of the conventional balloon.
All right.
Okay.
Balloon and stand. Last 3, right?
Yes.
All right. So, Dr.
Yeah.
We want to
Yeah.
move
Definitely.
Dr. Bak's lab, and then we will be back. Duk-Woo Bak,
Okay.
can you hear me?
Thank you.
Okay.
Great.
Okay, you can show you well. And as I mentioned, and we did our planned strategy, and this is a 3.25 cutting balloon. I applied the 3.25 cutting balloon. As we are, even though it's 내가 넘기할 때만 넘겨요. Even though we are the recommended cutting balloon is 10 ATM, we sometimes do is high pressure cutting balloon dilation. We inflated 18 ATM using cutting balloon 3.25, and then next one. And then we also additional the cutting balloon dilation 3.25, and we are 20 ATM impression, and the next one. And then this cutting balloon next one, and the next one, cutting balloon next one, and the next one, and the next one. And then this is immediately cutting balloon status. And the diagonal branch is compromised. And next one, we are do is 2.5 compliant balloon, and the next one, and then 2.5 compliant balloon, and next one we do kissing balloon. Is before applying the DCB, NC balloon, and the optimization is so important. Then 3.5 NC balloon, we apply the LAD to remain stand. And next one, we do the kissing balloon dilation in the LAD diagonal branch. Okay, next one, diagonal branch just 2.5 balloon here, and next one. And then next one, kissing balloon. And then we do additional NC balloon, the dilation in the sulcus ostium. And next one, 3.5, and we are inflated 28 ATM. And next one. And the next one. And this is a NC balloon, high pressure balloon dilation up to 28. Next one. 3.0. Yeah, it's both sides is 3.5. Right. And the left main is 3.5 in the NC balloon. And the next one. And then we inflated up to 30 ATM, 3.5 NC balloon, next one. And then we do final kissing balloon dilation, and the next one. And our final step, we apply to DCB 3.5 sequence freeze, 20 millimeter, and we apply the sulcus ostium. And next one. And 우리 그건 안 찍었나? DCB 할 때. Okay, here is a DCB, and the 3.5 20. So we are inflated, waited 45 seconds, and then we now apply to the proxy LAD left main, the DCB.
Okay.
맞지?
Slow down.
Okay, we are previous DCB is suck and put the more distal part. This is DCB 3, additional DCB 3.5. 잠깐만. Here. 메인 딱 맞지? Okay, booster 여기서.
Circumflex balloon is also DCB? Circumflex?
Yeah, DCB.
All right,
yeah. Okay, 6, 8, 10, 12. 야, 시간 재세요. 조금 아파요. Okay, we will left main DCB sometimes concerned about the BP drop and chest pain and ECG change. We should monitor well. There is some dynamic change and blood pressure dropping, and we should be released. Okay, 환자분 통증 있으면 얘기하세요. 20 seconds. Okay, blood pressure is good. Yeah, 조금 아파요. Okay, 30 seconds.
Speak English.
Yes, and the left main, okay. And nobody want more than 1 minute, and it's just, okay, 40 seconds. Okay, there are slightly ECG change. 45 is up to 50 seconds, okay.
1 minute, 1 minute.
Okay, and then we are final step. This is both DCB, and then we're gonna finish. 빼고. 3.5, 3.5. 자, 6씩만 갈게요. 잡고 6. In both branch. 6, 6. 6, 6, 7, 7. 8, 8. Okay, 1, 2, 3. Okay. That is our final step. And then after final applying the DCB, we don't more touch. Yes.
All right.
Okay.
So I think this is a great kind of educational example how you use DCB in bifurcation lesion, because that the DCB kissing is not recommended due to the several reasons. And Professor Bach did a left main to circumflex DCB, left main to LAD DCB, and then did the kissing not for the drug penetration, but for the mechanical rearrangement.
Okay, we're gonna show. Okay.
Great.
자, 컨트라스트 준비됐어요? Okay, ready? Okay. 자, push. Okay,
great.
costume is much better. And then spider view.
Spider.
Okay. 자, test again. Okay. It's good.
Perfect.
Diagonal ostium is much
Good
good.
enough. Good enough.
Yes.
Diagonal branch actually is good. Chemistry flow, right?
Yes. Okay. We do predilation. Okay. Test. Okay. 여기 어떤 뷰가 잘 보여? 더 줘봐. 오케이. 여기요. 자, 오케이. 왼쪽. Good. I think the diagonal ostium is okay. So we do final IVUS the evaluation. 자, 가면 돼.
We have enough time. Duk-Woo. Slow
Yes,
down.
yes,
All right.
okay.
Don't worry.
Is able person is very nervous.
Duk-Woo, is there any difference in terms of ISR cases, plaque modification using the cutting balloon or non-compliant balloon only?
자, 그러면 코 달라고 하고.
Habitually, we prefer cutting something like that. However, any
Yes, so there's a small data that supports that the kind of cutting or scoring balloon is working better than the high pressure balloon, but each balloon has a different meaning. As you know very well, that if there's a kind of mechanical under expansion, we should use
any data on there?
small data.
Okay.
Small data.
Yeah.
All right.
천천히.
But at least theoretically, we know that the cutting, especially for
Small
the,
data. You made it.
No. Professor Shin made it. Dr. Shin made it.
Okay. Okay, we're gonna show the OCT.
Good.
이게 사이드로 없는 거지. 네. If you use the guiding cast without side hole, you can evaluate the even left main complex PCI. This is ultraon system. Okay, 이 컨트라스트가 좀 덜 시켰네, 그지? Okay, there are some contrast, not clearly. ostium만 한번 보여줘봐. Okay, there are some plaque modification, suck ostium, and then okay, you can see that there are some plaque modification. We using cutting balloon and NC balloon. Is suck ostium is good, yeah.
It's good.
And okay, so I think we do is everything in the current status, and this patient is initially underwent gullo stenting and ISR lesion in
I don't like the
post-branch.
microscopic findings of OCT.
Yeah, so
right?
it's very difficult
wanna
to say
see
the
that.
clear, perfect images, but
Alright.
as mentioned in the last session, the lumen is more important than those some ugly flaps there. So lumen is super big, so I think it's a kind of perfect results in terms of
LA 한번 더 보여주자.
OCT.
여러도
Okay, so lastly, I'm gonna show the prox LED lamp main. It's able person is please show us some clear image. Okay, I'm gonna show us the prox LED to the lamp main. Okay. 좀
SJ Park, I have a short question to your SJ Park.
Okay, 잘 찍어보자.
Can I get a quick question? Because you mentioned for the diagonal management. In this situation, we have to measure the using the balloon, semi-balloon to the opening. And after that, do you have an opinion about using DCB or not in the when you TIMI3 maintain status?
Okay, much better.
particular these cases?
Yes.
I want to use DCB.
DCB?
Yeah, of course. Right, for
the lead or the DCB? Because we already done for the balloon.
DCB would be better. Why not? We need it.
Are there any difference between Limsa and paclitaxel? according to the OCT ISR findings.
잘 끝났어요. 오케이, 여기 잘 보인다. Okay, we're gonna show the more clear image. This is a plaque LAD to the left main, and then there is some plaque modification. I think lumen is good, and we did very aggressive high pressure balloon. Final step was DCB, and the distal left main circle is coming the 11 is at 9 o'clock. Yes, and the lumen was enough. Okay, so I think the result is good, and if this patient recurrent ISR again, we should consider re-DCB or the bypass surgery.
Great, Dr. Bang. It's really good cases. Very tough ISR for the main disease.
Okay, go ahead.
All right. So, thank you for a nice demonstration. You want to see?
Okay, thank you.
Do we need imaging after
아까
DCB?
중간으로 갈까요?
Is there any
끝난 데부터?
possibility drug comes off the wall? Is there any possibility drugs comes off the wall after imaging?
I don't think so. I don't think so.
그다음.
Okay, okay.
Seung-Jung.
Yes. I did something after the OCT evaluation. I applied 3.0 NC next. Because the vessel size was 3.3 at the mid region. I did the 3.0, and next we could see that it's very expanded. And next. Minus. 다시. Minus. Yeah. This is 3.5 NC. Yeah, and very expanded.
Okay, and then
And after that, next.
final 38.
Yeah, this is a long 48 stent to cover the whole region with one stent. 3.0 by 48 giant stent. Next. And stent is expanded well. Next.
Did you cover the left main dose? Left main too?
Yes, I covered left main.
All right.
We could see that the plug is the continuous from the LAD to left main, so we could not just cut the stent at the proximal LAD. It's up to intravascular imaging finding. Next.
Good.
And applied several balloons, 3.0 and 3.0 and 3.5. And shall we check the angio? Yeah.
Perfect.
Now we are here.
All right.
OCT.
Cover the whole left main though, right?
Yes.
So what size of a proximal LAD is still there are some, how can I explain that, on the expansion of the...
Yes. I can see there is a little bit on the expander, the mid LAD just proximal to septal, and just proximal LAD looks not so much enoughly big, so I will check the image and we'll consider the bigger balloon or not. I applied 3.5. And because the vessel size at the proximal LAD was 3.7 at the OCT, so I applied 3.5.
Okay.
And applied up to 30 ATM.
Final OCT?
Yeah. Yep. Angio. Okay, let's see.
Good.
There is a little bit spasm. The distal vessel is smaller than
Good.
before.
Stem position.
The landing is good. Yeah.
너무 아프죠.
쭉 손으로 쭉 빼볼까요? Yeah. And you can see the eccentric, but the shape is quite good.
Great.
Considering the angiographic severity or OCT severity, which and proximal region. You can see multiple crack and
stent area is quite enough.
Yeah, stent area is more than 9, and proximal LAD and main.
Great.
You can see a small dissection that was from the proximal LAD to left main, and we covered it. Yeah. Angio minus.
I think it's good. Calcific region. IVL preparation, and then long stent for the
angio.
Perfect.
Good.
Any other view?
check the spider.
Circumflexor stem is good. Spider is good. Perfect.
It looked okay in the
All right.
intravascular imaging, so I did not protect it. And let me check the spider view. Yeah. It's
okay.
about 50% stenosis. However, the circumflex is non-dominant and flow is good, so I
What
do
about
not
the-
want to more.
Dr. Gu, what about the FFR?
FFR will be fine because it's very focal, around 50%. Just
Right.
it will be
So
fine.
more than 0.8 something, right?
Yeah, it's higher than
All right,
0.8.
right. I
yes.
think it's okay.
Yeah,
Dr. Gu,
okay.
all right. Functionally, it's good. In morphologic some compromise, circumflex is not a big deal. So we want to present it. All right. Dr. Kang,
Minus.
really good cases, right? Tip is wrong, calcified region. We will learn a lot, right? Thank you.
Thank you so much.
Okay, you want to move Dr. Han Jung-Kyu from Seoul National University. All right, Dr. Han, can you hear me?
Hi, good afternoon. I'm Dr. Jung-Kyu Han from SNU Hospital.
Right, we have Dr. Bon-Kwon Koo and many distinguished panelists here. And so we are all waiting for your cases. Right.
Thank you. First, let me introduce our team today. We have Dr. Jun-Yoon, who is our clinical fellow in his second year. We also have surgery operator, Dr. Sang-Hyun Park, who is a clinical fellow in his first year. We also have Mr. Jeom Lee, who is a radiologist, cardiologist, technologist. And IV's commentator is Dr. Jinon Sung, who is a clinical fellow in his third year. So let me present our today's case. 슬라이드 보여주세요. So today's case is a 51-year-old gentleman. He recently developed non-exertional chest discomfort, and he took a coronary CT angiogram, and he showed a very severe extensive coronary calcification, and calcium score is higher than 1800. Next. So here is diabetes, hypertension and dyslipidemia. Next. And target lesion is proximal to middle LID diffuse lesion with heavy calcification. So we are going to use IVL today. Next. Chest X-ray and electrocardiography showed normal findings. Next. Echocardiography showed normal finding with preserved ejection fraction. Next. And outside the coronary CT angiogram showed extensive calcification all the way through from proximal to middle LID. And stenosis severity couldn't be well assessed because of bulimia artifact. Next. There are also calcified plaques in circumflex artery and RCA. Next. So 1 month ago, we took a coronary angiogram. That angiogram showed proximal to middle LID heavy calcification. You can appreciate it in pre-contrast image in the middle. And just after calcification, there's some bicardial breaching at the middle LID. Next. And epicaudal view, you can also appreciate proximal to middle LID with heavy calcification, and there are intermediate diffuse lesion in circumflex artery and RCA. Next. The FFR taken at distal LID was 0.77, so patient has this chest discomfort and FFR is lower than 0.8, so PCI was indicated. Next. So you can see the IVUS on right. The IVUS show the myocardial breaching and then eccentric calcium stats. So heaviest calcification were located in between D1 and S1, and also next D2 and S2. And by the way, there's a small diagonal branch which obscure ostium, but I don't think we can intentionally protect it, so I ignore it. So there's a D1, S1, and D2 and S2 next. The MLA was observed just before the diagonal 2. The MLA was 2.6. Next. This end of calcium was located just after S2, spanning 2 to 3 millimeters. Next. And just after that, there's myocardial breaching. Next. Distal reference diameter is 3.0. Next. And proximal reference diameter at the very proximal end of LID was 5.0. Next. So the issue in the patient is IVL in patient in myocardial breaching is safe. Next. So my plan is I'm going to focus on the heaviest calcification between D1 and S1 and D2 and S2, next two. So I'm going to deliver 30 to 40 pulses to heavily calcified segments, and then 10 to 20 pulses to remaining LAD segments. Next. And I'm going to place the distal balloon marker of IVL at S2, and then distal end of calcium spanning 2 to 3 millimeters are located. Next. And the length between the distal balloon marker and the distal emitter is 4 millimeters. So what it means is next. If I place the distal balloon marker at S2, I would get 6 to 7 millimeter of safety margin. And acoustic pressure declines 3 millimeters away from the emitter. So hopefully 6 to 7 millimeter safety margin would be okay to avoid any risk of perforation and myocardial breaching. So that's it. Do you have any comment or recommendation, please?
So, Dr. Haeng, it's a very meticulous planning based on imaging and angio. So, are you concerned about the potential risk of the vessel injury in myocardial bridging segment? Is there any data that supports that concern?
Yeah, it's a very important question, and I try to find any previous data or case reports regarding the patient with myocardial breaching undergoing IVL, but I couldn't find any useful information. I even asked the company, but what I found was that there's only limited experience and data in this kind of patient. So safety comes always first. So I will get the safety margin. So although if there's some distal calcification there, so the finally there's some possibility that we would get some suboptimal result expansion of a stent at very distal end of a stent, but I would accept it probably, and we'll see what will happen.
Okay, any suggestions or comments from the panels?
Dr. Koo, for a case like this, we got the myocardial breaching in the LAD, and we do the FFR, but this is just a conventional FFR.
Yeah.
So we worry that, may not be reliable. And then the second thing is that this is already tortuous. The distal vessel is very tortuous. So once we do the pressure-wire FFR, according event may happen, and they may affect our FFR as well. So for a case like this, will you just normally trust the FFR, or will you do diagnostic FFR or IFR? No?
I think that's a kind of the good reasoning, but if you see the pullback numbers, I think it's very reliable.
Okay.
And as FFR is already positive, so we don't need any stress test for this breaching. So that we need to be care about that issues, but this pullback images and pullback numbers, I think it's very reliable.
Okay, so in that's the case, the myocardial breaching maybe is the one causing the problem. So how you differentiate whether it's a lesion causing the problem or the myocardial breaching causing the problem? Or can be both?
So we can explain many kind of physiological explanations, but I think the focus is not the breaching, but for the calcium. So why don't we just focus on calcium here?
Okay, so Dr.
So now we have only 23 minutes, so I'm going to start the IVL.
So IVL balloon size?
balloon size is 3.0 by 12. 자, 엔지오 좀 띄워주세요, 방송화면에.
3.0.
Yeah, so vessel size is 3.0. We are targeting one-to-one match to intended stent size. So I'm going to place a 3.0 stent. Finally, so I'm going to perform the IVL. IVL, we are using the.
And you didn't do any pre-dilatation?
Yet.
Okay. So guiding catheter is M plus 7 French?
M plus 1.5.
7 French?
Yes.
Okay.
So actually, I tested whether the IVL catheter could pass through the region previously well done, but so I need definitely pre-dilatation. 3.0 NC balloon 주세요.
The mid-LAD lesion in heart might seem to be the eccentric calcification, different from the proximal part. So in such a region, the sometimes the rotablator or the orbital atherectomy, like atherectomy device, is better than the IVL. So in such a case, the predilatation, as a predilatation, by using the balloon, maybe the dissection will be created. So the rotablator might be better than the usual balloon.
Yes, it's another option. Then I'll try to do the predilatation. If it doesn't work well, then I'm going to do the rotablation.
So
because IV catheter could pass smoothly without any resistance, so I didn't expect this.
Balloon passes very well. 3-0 NC balloon, but it passes very well.
Yeah, test.
Okay, we'll see.
Yeah. Well, we may need the guided extension. So I'm gonna go to 8 ATM. The nominal is 12, but I'm gonna be safe. 12.
Size of balloon 2.5?
3-0.
3-0.
3-0.
12. Yes.
So the question is, do we need a balloon for that segment as well, proximal? Because that segment IVL has passed.
Between the D1 and D2, yes.
Because you're going to do the IVL
but there's
anyway.
Yes. There's heavy calcification between the D1 and D2, the D1 and so on, deflation. 토크 주세요. I'd like to save the D2 because D2 originates with at a sharp angle, and there's heavy amount of plaque with heavy calcification. So I placed the wire, but I lost it. So AP 꽂아 주세요.
So with the previous case and this case, we are learning about some, strength and weaknesses of IVL, but the pre-procedure planning is very important, even using for IVL.
크레인 주세요.
So it's after balloon angioplasty, so it may not be easy to rewire through the dissected plans.
So I did it.
Great.
Perfect.
And then I'm going to pass the IVL caster. If it doesn't work, then definitely I'll do the rotablation with 1.25 bar. 자, 주세요. 가이드 익스텐션 좀 까기 직전까지 좀 준비했어요. 네.
Okay, good.
Test. I'm going to place the distal balloon marker here, S2, for ATM. 스탬 부스트 준비해 볼까요?
Okay. So balloon expansion seems to be nice.
Deflation. 네. I'm gonna slightly pull back the IVL caster 1 to 2 millimeters because the spots closer to the emitter will receive greater energy. 자, 다시 사기압. Do you see the, yes, you see the stamp is live.
Yeah.
And the live image, you may see the emitters, 2 emitters.
Yeah.
6겹. Deflation. Again, 1 to 2 millimeters pulling back, and 4 ATM. deflation. So I'm gonna deliver 40 pulses this area. 사기압.
I mean 40? 14?
Yes.
14?
Yeah, 40 pulses.
Okay.
Each time we deliver 10 times, 10 pulses. 6기압. Different. And I'm gonna pull back 10 millimeters with a 2-minute overlap test. Okay. 자, 4기압. 주세요. Deflation. Pull back some millimeters and then for ATM. 주세요. 네, 조금 답답할 수 있습니다.
So these balloon images provide the information how good the preparation is. That in some poor preparation there's some air which reduce the effectiveness of the shock.
테스트 살짝. 오케이. 4기압. 주세요. Deflation. Because SD is elevated, so we'll have some perfusion time. Okay, SD is downing now. So test. 50 pulses are remaining. So I'm gonna do 3 times more here. 4기압. Pulse.
So Dr. Han, you will not touch the left main.
Yes.
Okay.
But left main size is higher than 6 atm. Deflation. Diameter is more than 5 millimeters. So even though we place the balloon caster there, the left main will not be affected.
Okay.
M2 좀 주세요. 네, 괜찮습니다. Okay. We have 40 pulses more. M2 좀 주세요. 4기압. 펄스.
I'm afraid that the flow to the diagonal branch have been deteriorated. So after this
I
shock,
think so,
maybe you
yes.
can check the diagonal branch flow.
Yeah. 컬리메이션 좀 풀어주시고. 아니, 다 풀지 말고. 뭐. For ATM. Pulse. 육기압. Different. He suffered some chest pain, so I pulled back the balloon.
Yeah. Can you just check
perfuse
the angio?
myocardium.
Can you just check the angio?
Yes, I'll do.
Yeah, so diagonal branch is occluded.
Yeah. I only have 20 pulses now, so I finished the IVL and then save the diagonal branch. 2.0에 15번은 트랙 좀 주세요. 자, 4기압. 2번을 빨리 합시다. pulse.
So generally, when we do IVL, we generally do not care that much about the side branch flow deterioration, but I think it's due to the previous balloon inflation, which make a dissection propagated to the ostium of the diagonal branches.
자, 엔지오를 보여주세요 이제. 자, 그리고 so I delivered 120 pulses through the proximal to medial AD, and I'm gonna save the diagonal branch.
So this case illustrates how important to put a wire before doing any procedures for the branches. So placing the wire makes facilitate procedure easily. But if there's no wire at this stage, the operator generally in trouble to advance the wire through the several dissection flaps. So 2-0 balloon for diagonal branch?
Yes.
Okay, we'll see. Okay, balloon passes very well.
이거 줘야 돼. 디플. 좀 빼서. 8. 디플. 8. 디플. I'm gonna check the flow now. 준비.
Okay, good. Very nice, very nice.
So finally, I'll do the NC ballooning before placing the stent. 3.0 NC 한번 다시 주세요. Stay. 빼지 말고.
And your strategy for this diagonal branch is maintain TIMI3 flow.
Yes.
Okay, so agreed.
환자분 괜찮습니다. 잘 되고 있습니다. 걱정 마세요.
So now TIMI3 flow have been recovered to all branches, so the patient will be stable. So you're advancing the stent?
No, NC balloon
NC
finally.
Balloon? Okay.
Yes, and then I'm gonna place the stent.
So
before that, I'm gonna gel the corsair balloon to diagonal 2 test. Okay. 노미널이 12이었나요? 자, 10.
So you mentioned you're going to do a jailed balloon technique for that diagonal branch or jailed corsair?
jailed microcut, jailed corsair technique.
Jailed corsair technique.
12. Yes. 14. 16. 디플. 16. 18. 디플. 자, 익스텐션 카테터 주시고 코세어 좀 끼워줘요.
So if you have to do, in general, there's no difference between jailed balloon or jailed corsair technique, but in this case, the stent will be covered through the calcified segments for a very long segments. Jailed corsair may be much safer in terms of retrieving the system.
갑시다.
So you still have 5 more minutes, so please take your time.
와이 잡고 팽팽하게 잡아줘요. 자, 와이 밀려 들어가. 와이 팽팽하게 잡으세요. 자, 스탠트 준비해 주시고. 네, 2.5 22. I'm gonna press 2.5 by 22. Then post dilatate to up to 3.0 to be safe, because I'm gonna place a first stent beyond the S2, so there's some risk of stent is placed in the myocardial breach segment. 자, 주세요. 갑시다.
So there are several ways to protect the side branches, especially relatively small branch, which do not have an indication for stent. So gelled balloon technique, gelled corsair technique.
노미널 얼마죠? 자, 시내해볼게요. 테스트 해보세요.
Protection.
Yeah, stent will gel the corsair, but
Yes.
maintain flow.
So I'm going to place a
flow
stent
at least.
here. 12. 15초.
Okay, stent expansion looks good.
10초. Different. 15초. 20기압. 20기압 10.85. 20. Different. AP 코드를 주세요. 길이 좀 재볼게요. I'm going to estimate the length of the second stent. Test.
Okay, looks good.
Because very proximal part of the LAD is saved, so I don't need to touch the proximal LAD, I mean the ostium. A cranial. 여기서 한번 씬해 볼게요. 이게 생각보다 짧네, 그지? 20 길이가 생각보다 짧네. 22 해도 되겠네요. 이거 하나 더 줄까요? 3.5에 22.
Are you going to remove the corsair before implanting the proximal stent?
Yes, actually, that's my initial plan. But I only have 3 minutes.
Because
I may try it, yes.
at least
Actually,
you have
yeah.
a good flow, and the jailing very long segment may not be that safe.
Talk. Yeah. Then I may try to wire the T2 using this wire, because wire is placed in the Truman.
Okay.
그 익스텐션에 커세어를 좀 끼워줘야 지 서포터가 필요하네요. I'm gonna remove the first wire. Maybe I can facilitate the wiring, no? Okay.
Yeah.
Okay. Then I'm gonna perform the NC ballooning to oppose the stand 3.0 balloon to the vessel wall, and then I'm gonna do the rewiring through the LAD. 3.5를 빨리 주세요. 다이고널 쪽에 프록시마 LAD를 할 거예요. 다이고널 직전까지 어포즈를 시키기 위해서. 3.0 발룬, NC 발룬, 그 뒤에 스탠트 꺼내줬죠? 네.
So Dr. Han, you have some extra minutes. So even though broadcasting time is almost close, so that please take your time. So
Okay. Prep.
and your implant
test.
So okay.
No, this is balloon. So oppose
okay.
the balloon
Okay.
stand. 지금 NC죠 12. Because the second wire can go through in and out of a stand strut. So before removing the jailed crosshair, I need to oppose the stand strut to the vessel wall. 자, 익스텐션 주시고 토커 주게 돼요. 이거 리시핑 해야겠다. 자, 주세요. 와이어 꺼내주시고.
This procedure is, I think, very smart because that in October trial, there's many unintended stent deformation due to the false wiring, which was strongly associated with a poor outcome when left untreated. So Dr. Han did this to prevent the abdominal wiring and subsequent stent deformation.
Yeah, that's a very important point. And actually, because of that, sub-study of October study definitely showed the stent strut deformation quite frequently happens, and it's associated with worse outcome. So that's why I did it. Apicoder.
So this is live demonstration because some operators miss that kind of important small steps to ruin the whole live demonstration.
Test. Okay, so I think 2 wire are all in the entrance stent. 자, 주세요. 스탠드. 빨리 주세요, 일단. 스탠드 차트 주시고.
So stent diameter length will be 30, 35?
35.
35, okay.
Because 3.0 onyx stent can be expanded up to only 4.0, and very proximal end of LAD is 5.0. So I selected 3.5 because that can be expanded up to 5.0. Test. 스탠 부스트 한번 해볼래요? 라이브. .0에 15 NC 좀 주시고 3.5 꺼내줘요. 부스트 됐나요? 네. 오케이. 풀어주세요. 테스트. Is this so much short?
Yeah, a little bit short.
If needed, I may place a very short stand to the proximality. 자, 갑시다. 12. Deflation. Yeah, diagonal branch is again compromised, but it's okay because the wire is placed in the two-man intra-stand space. 에이프코더 좀 줘볼까요? 2.0 걸로 한번 다시 주시고. 스내 준비. 에피크레니얼. After saving the diagonal branch, and then I'm going to show you the IVS finding, and then if there is needed any additional stent to the proximal LAD or any post-dilatation.
Does patient complain any chest pain at this time?
Right now it's okay.
No? Okay.
가슴 불편하진 않으세요? Yeah. He suffered some chest discomfort now.
The symptom is quite sensitive to that small diagonal branch, even though it's not that big.
Wire is jailed.
Yes, why should we change its talker? Because it's
the wire is,
by the
proximal stent jail the diagonal
Yes.
branch wire. Maybe safer to use a new wire because that you made several.
Yeah.
Okay, but
Test.
it's good.
But wire is inside the. Yes, I need some support. 코세어에다가 저거 좀 끼워주세요. Extension. 끼워줄까요?
This case reminds me of Dr. Columbus saying that you have to finish your bifurcation PCI with the same numbers you started with. So Dr. Han is trying to maintain TIMI3 flow to maintain the same branch numbers he started with. Okay, so Professor Han, so we are behind the schedule, so 6 minutes over. So can you briefly introduce your final plan for the strategy? Because it may keep key issue, calcium lesions are already very well treated safely.
Yes, after saving the diagonal 2,
Okay.
and then I'm going to perform the IVUS.
Save the floor for the diagonal branches,
Yes.
right? All right. Good.
Yes, and then I'm going to perform the IVUS. Then, if needed, I'm going to do the post-dilatation or placing any additional stent through the proximal LAD. I may need a new wire. 시온 블랙 하나 더 주세요.
Great.
Okay, thank you, Han and SNU hospital team for your great contribution and dedication to the study, to this live, and we look forward to see the final result. But we are going to leaving now. Thank you, Professor Han and the team.
Great cases,
Great.
Dr. Han. Thank you.
Thank you.
See you next time again. Right. Okay, you wanna move lecture sessions? Bon-Kwon will give us a Physiology-Guided PCI 2025 Guideline. Class 1A. Please.
Thank you, Professor Bach, for the kind introduction and invitation. I'm BK Gu from Seoul National University Hospital, and these are my disclosure. You may or may not know the history of coronary physiology is exactly the same with the history of PCI. And this first invasive physiology in PCI was done by Dr. Grunchik, and this evolved into the concept of diffraction flow reserve and first validated in human in 1994. After that, more than enough data had been accumulated, and in 2010, FFR-guided PCI has become a class 1A indication, and we know that it's still 1A with IFR. So today we are in the Complex PCI Symposium 2025 to learn how to make it simple. So here are 3 cases, mostly bifurcation lesion, mid-LAD true bifurcation, distal left main to LAD, and 14-year-old jailed branches for circumflex and diagonal branches. So for complex procedures, the question may be which technique, how complex it will be, but before you do the procedure with the pressure wire, give some adenosine or sigma, you get the different finding. LAD 0.89, diagonal branch 0.94, left main to LAD 0.85, for these jailed branches for a long time, IFR, FFR, all negative. So it's not a matter of complex PCI, but how good your medical treatment will be. So it's a simple. So here's another scenario about complex case. Here's another anomalous RCA from left sinus of Valsalva. So the question is whether PCI surgery is needed. You made some complicated procedure using dobutamine, atropine, adenosine to do a stress FFR, but you will see that even with the stress FFR, it is 0.87, so PCI and surgery is not needed, simple medical treatment. Here's another case, CT positive, asymptomatic, significant stenosis, so asymptomatic, so FFR was measured, 0.66, stent implanted, looks good, so I and the patient should be happy. The question is, do we still need a further assessment after this kind of optimal revascularization? This is ischemia-directed revascularization, which is similar to the ischemia trial. But if FFR is measured, it's surprising that it's 0.73. There's a huge step up at the hidden proximal lead stenosis. If I finish the procedures, I might be happy by the angio, but the patient would not be. Some may argue this is rare case example, but unfortunately, it's not. in this IPD meta-analysis, suboptimal physiologic PCI happened after successful angiography. Around 1 out of 3 patients, and even 1 out of 10 patients left the cath lab with the residual ischemia, and this is associated with the poor outcome, especially increased risk of death or MI. So coronary physiology, it's 1A for optimal decision making, but it can be also used at the PCI optimization. And yesterday and today we learned about great insight about the intravascular imaging, and now IVUS and OCT is class 1A for stent optimization. And we also learned that it can be used as somehow decision making. So the question is, if you and I have to choose one, either physiology and imaging, the question is, which will be better? So that was the question we had several years ago, and the baseline for the fractional flow reserve and IVUS comparison in the FLAVOR trial. So in this trial, we show that no difference in clinical outcome between FFR versus IVUS, and no difference in quality of life, but FFR was associated with the 43% less PCI in target vessels and almost 20% less DAPT. So it seems FFR is more effective in terms of in reference to the IVUS. Recently, we performed an extended follow-up for 7 years, no difference in death, MI, but in terms of any revascularization, there was a more event in FFR group, which make a significantly higher revascularization rate in the FFR group. So it's similar to the PREVENT trial. So the question is how good it was in a cumulative target PCI burden, which combined the index PCI plus PCI during follow-up. So at the index procedure, there was a difference in the PCI rate, 25% lower in FFR group. At the time of 2-year follow-up, it reduced to 24.5%. And this narrowed down to 21.7% at 7 years, still very significantly low in the FFR group without any difference in the risk of death or MI. So all these study results support that the FFR is effective. But we know that it's been class 1A for 15 years, but still underused. There are several reasons: cost reimbursement, resource issues, and psychological issues. But that's the reason for the image-based physiology assessment to make a simpler physiology-guided PCI. And this starts with the CT-derived FFR, and now we have an angio-FFR, IVUS FFR, OCT FFR. So practically, any imaging can be translated into the physiological assessment. We know that the FAVOR-3 China trial provide the clinical evidence that as it showed that the clinical outcome better with the QFR-guided PCI in terms of angio-guided PCI. And since 2024, it became class 1B indication. But FAVOR-3 Europe failed to prove its non-inferiority in comparison with the FFR, so the data are contradictory. And this year, we had a FLAVOR-2 trial. The difference between the FAVOR-3 Europe and FLAVOR-2 is that the FAVOR-3 Europe used QFR only for the decision making, and in this FLAVOR-2 trial, we used angio-FFR for both decision making and PCI optimization. And in 1-year follow-up, there's no difference between angio and IVUS, so this is a kind of positive signal for the image-based physiology. And next year, we will have two large randomized trial, FAST-3 and ORISE, which will define the role of the angio-based physiological assessment in terms of clinical outcome. But the best element of this image-based physiology is it can evolve into the integration of whole insight, lumen, plaque, and physiology with the AI. So here's a case example. 2 different persons, 50-year-old female and 80-year-old female and 59-year-old gentleman. By lumen definition, physiology definition, plaque character, these 2 patients have the same lesion: obstructive, ischemia, and vulnerable. So the treatment should be the same. But when we integrate all information using the AI, you can get a different insight from these numbers. So AI is telling that this above female has a much higher risk than the relatively young patients. And what happened to these two patients? The first patient has an ACS event in around 6 months, and second relatively young patient is stable for 2 years. So this is my take-home messages. Invasive physiological assessment is and will remain as a Class 1A recommendation and should be a cornerstone of PCI decision-making and also its optimization. Image-based physiology, we still need more data, but it can definitely provide less invasive physiological information and definitely facilitate more effective integration of imaging and physiology. Finally, the future of CAD assessment is not whether imaging is better, physiology is better, but the combination of anatomy, physiology, and AI-enabled risk assessment to define high-risk lesion and guide the treatment, either medical treatment or PCI. Thank you very much for your kind attention.
Thank you. We're going to move next to talk. Dr. So-Yeon, Jon Suh, will give us imaging-guided strategy for the managing calcified coronary lesion. Please.
Thank you, Chairman. Good afternoon, ladies and gentlemen. I'm Jon Suh from Korea. This is my disclosure. As I present this topic, I'd like to consider 3 following questions. Why we need imaging modality? What are the practical applications? How can we plan imaging-guided treatment? First, why we need imaging modality for the treatment of calcified coronary lesions. First of all, why we need imaging-guided PCI? What does British Prince William's finger gesture mean? This is a people over numeragram. As you know, severe calcified coronary lesion related to fail to cross the lesion, stand under expansion, and leads to adverse cardiovascular outcome. And there are limitations of angiogram for calcium detection. As you know, RENOVATE complex PCI trial was the first trial which confirmed the survival benefit of image-guided PCI for the patient complex coronary lesion, including severe calcification. Not only RENOVATE trial, but also other representative trial of image-guided PCI resulted in low incidence MACE than angio-guided PCI. Indeed, result of trial raised the guideline recommendations to the Class 1 level of evidence A. What are the practical applications of imaging modality? First, CT. Coronary CT provides information about the extent of calcification. Cross-sectional view depicts the circumferential expansion extent of calcium. A novel cardiac CT can measure the calcified angle and mass, bifurcation existence, and calcified distance. And we can estimate the percentage of use of atherectomy devices. How about the intracoronary imaging? IVUS is better for the estimation calcium in a large vessel and aortic ostial lesion. OCT is better for malopposition assessment. And criteria of calcium severity and risk of stent under expansion consist of superficial calcium longer than 5 millimeters, circumferential superficial calcium, calcium nodule, and vessel diameter in IVUS. In OCT, calcium maximal angle and thickness, and calcium length. So IVUS calcium score has a 4-point score evaluation system. As you can see, thick calcium indicated the posterior acoustic shadowing and thicker than 1 millimeter. Reverberation present superficial calcification. And OCT has a 4-point score system evaluation system. OCT can measure the area, calcium area and angle, and their thickness exactly. So how can we make strategic planning of image-guided treatment? Sky expert consensus statement demonstrated that criteria calcium modification are based on intravascular imaging. After intravascular imaging, we can choose the proper treatment modality. After use of treatment modality, consensus statement recommend repeat image evaluation for calcified lesion modification. European consensus statement also emphasized the imaging guided assessment. If calcium score over 3 or IVUS calcium score over 2, they may be preferred to choose the lithotripsy or atherectomy. And also emphasize the repeat IVUS OCT before the stent optimization. Let me show you some of my case. 78 male of unstable angina. The baseline angiogram showed the significant calcified stenosis in distal RCA. IVUS revealed the superficial calcification, decalcification, and circumferential calcification. So his patient IVUS calcium score 2 because of superficial calcification longer than 5 millimeters and circumferential calcium. So we decided to perform the cutting balloon procedure. After cutting balloon, we can recheck the IVUS for the calcium modification. So, and we can stent delivery successfully like this. Another case showed the severe angulate calcified on mid-LAD. IVUS cannot pass the lesion. So based on the CT information, we can measure atherectomy risk score 3. So after small ballooning, we can check the IVUS. Patient IVUS calcium score 3 because of circumferential calcium and calcium nodule. We performed the rotational atherectomy. After atherectomy, we can recheck the IVUS for evaluated calcium modification, and we can get a good result. Last case, patient has a high bleeding risk. Patient angiogram showed severe calcified lesion on proximal RCA. We decided to perform the intravascular lithotripsy because his OCT score 3. After IVL, we can get a significant luminal gain and calcium modification. Final angiogram showed the OCT-guided stent optimization achieved in heavy calcification, like this. However, we are still wondering how to pre-treat calcified lesion is best. Which PCI device should we use in the calcified lesion? So, shortcut trial and Victor trial were published. There are several trials ongoing. This is my conclusion. Multimodal imaging offers more comprehensive insight on the pathophysiology to assess coronary calcification. This is confirmative. Use of imaging-guided strategy enhance the procedural success and may contribute to improve clinical outcome. Thank you for your attention.
Great, thank you. Dr. Gu, any discussion point about that one?
So any questions, comments? Because that we learned a lot about from the previous two cases, how the IVL can facilitate the system, but it also has some strengths and weaknesses, and physiology has been working for a very long time.
I have a question about you. We're going to move in terms of QFR, anyway, CTFFR, so imaging combined, physiology concern. However, look at that. FFR is kind of a coronary floor from the proximal to the far distal, kind of a total perception of a lesion, so whatever reason, it's a diffuse disease, some. How would you, compensate in terms of a CT-FFR and the QFFR. What do you think about it?
Yes, I agree that I've been measuring FFR for more than 20 years. So for me, measuring FFR is almost very simple. So I can do whatever measurement I want. But the problem is that the penetration rate. So, and I understand that there's some inter-individual variability in angio-FFR with any kind of system. But they are in 1B due to the favor 3, China, and in trouble due to the favor Europe. But the next year, no matter what my perception on image-based physiology is, if there's a positive 2 trial, it will become 1A. So the question is, it's not a matter of the kind of fundamental concept. The practice will adapt the image-based physiology. So, but I fully agree that it cannot provide the 100% or the 90% kind of sureness about the physiological assessment, but it will become more popular than invasive physiology.
Any others? One more. All right. Question. Post-PCI FFR concern, right? So post-PCI FFR is lower than, some criteria, something like that. However, that means that I think the PCI procedure is not perfect. I don't think so, right? However, post-PCI actually representative for the remaining diseases subset, right? And so sometimes that is really, clinical, prospective factors or not. I'm not sure.
Yes, I cannot agree more about your, understanding of post-PCI FFR. So I think the question is, if post-PCI FFR is low, the question is it a modifier factors or risk factor that cannot be modified? So there are some cases where you can find a significant underexpansion or the residual stenosis, but when you do a pullback, it's generally diffuse. So once it is diffuse, there's nothing for you to do. Maybe Professor Colombo want to do some DCB, but generally you cannot fix it. So it's like, when you do not have a significant pullback at the post-PCI FFR, I think it's like a glucose level. It's diabetes or eGFR level. So it's a risk factor you have to make in your mind that the patient risk will be very, very high during the follow-up. So, but it's not a kind of the question is actionable item or not, but I agree that in most cases, when you are done, especially after the image-based physiology, and your data also demonstrate that the good image-based physiology, post-PCI FFR do not have a significant impact on clinical outcome. So that's a very important message. Okay, so this was the live case session 3, and I learned a lot about this live demonstration and lectures, and I hope that all of you also had a very important insight about the complex PCI, and I thank the live operators and Professor Bach as a co-moderator, and also panelists and the speakers, and also the audience for the participation and great attention. I close this session. Thank you very much.